Hi, my name is Anna Harper. I am in Advanced Health Assessment, and this is my video on respiratory and cardiac system. This is my patient Steve, and he's a 32-year-old male who has agreed to do this video with me. The first thing I'm going to do is the cardiac system. We're going to go ahead and when I come in the room, we'll go ahead and look at his chest, making sure that the color and symmetry are equal. Noting he does have freckles on his skin from the sun. Next, we're going to palpate the apical pulse. And it is at the 5th intercostal space at the mid-clavicular line. So right here, we can feel it, and while we do that, we're going to check his carotid and make sure that they're equal, and they are. Next, we're going to palpate the chest and making sure that we don't feel any lifts, heaves, or thrills. You just follow the outline of the heart. Okay. And I do not feel any lifts, heaves, or thrills. Next, we're going to percuss the heart size. We usually do that with an x-ray, but since we don't have an x-ray, this is how we'll go ahead and do it. We'll start at the anterior axillary line and move down the heart, feeling for any dullness that indicates a border. Otherwise, we want to hear resonant sounds. And in the normal setting, you would draw on the patient just to kind of outline that heart, but for the video sake, we're not going to do that today. Next, I'm going to go ahead and auscultate his heart. We're going to do that for 1 minute. Normal is 60 to 100, and we're going to auscultate that at the point of maximum impulse. So you can go ahead and start my watch. And for the sake of the video, we're going to go ahead and auscultate that for 15 seconds and multiply it by 4. And so his heart rate was 82 beats per minute. Next, we're going to go ahead and auscultate the heart, starting at the aortic. Moving to the pulmonic, Erb's point, tricuspid, and mitral. While listening, I noted the rhythm. I heard S1, S2. I did not hear S3 or S4. I also did not hear any snaps, clicks, gallops, or rubs. I did not hear any murmurs either. If I did hear a murmur, I would make sure to note timing, duration and pitch, intensity, pattern, quality, location, and radiation. And any variation to anywhere else in the body. We're now going to go ahead and listen to his heart laying down and in the left lateral recumbent position. And when I do that auscultation, I will use the bell of my stethoscope. If you can turn on your left side, using the bell of my stethoscope. Okay, you can sit up. That concludes my cardiac assessment. We'll now move on to the respiratory system. So first, we will go ahead and inspect the chest for symmetric, making sure both sides are symmetrical, shape, making sure he's not barrel-chested, no pectus, and then we'll note any accessory muscle use, which there is none today. We'll note the AP diameter, which the AP you want half the size of the lateral, which is 1 to 2, and that is normal on him. And then the prominence of the ribs. So he looks like a healthy, nourished 32-year-old male. We'll note the anatomic landmarks. So we have the trachea, which is midline here. We have the suprasternal notch and the angle of Lewis, and then the costal angle here. And then if you wouldn't mind turning around, we'll note cervical 7 and thoracic 1. Next, we're going to go ahead and palpate thoracic expansion. So we'll go to the 10th rib down. Putting my thumbs together, I'm going to ask my patient to take a big deep breath. And my hands and thumbs rise equally bilaterally. Next, we're going to go ahead and palpate crepitus. Go around the front. And I do not feel any crepitus, which is a normal finding. Next, I'm going to check for tactile fremitus. We're going to go on the posterior side, place our hands on our patient's back, and ask the patient to say 99.
99.
Okay. And that was present, so if it wasn't present, we would note some kind of consolidation to be present. Next, we're going to do diaphragmatic excursion. We're going to go down to the 10th intercostal space with percussing. Usually it's around the 10th. Ask our patient to take a deep breath and hold it while we percuss, and once we don't hear resonant anymore and we hear dull, we'll mark that on our patient, and we'll do it again with the patient taking a big deep and breathing it out and holding, and mark that. And then our measurement should be between 3 and 5 centimeters for a normal finding. So we'll go ahead and do that. So Steve, if you can go ahead and take a big deep breath and hold. Okay, now you marked it. Okay, breathe. Then we're going to go ahead and take a big deep breath in and breathe out and hold. Okay, breathe out. Okay, then we'll take our measuring tape and measure. And the measurement for him was 4 centimeters, and that is within normal limits, so that is a normal finding. Next, we're going to go ahead and percuss the chest. We want to hear resonant sounds. Any dull sounds would indicate that something, some kind of consolidation was present, and making sure that they're equal bilaterally. And that is also a normal finding for him, all resonant sounds. Next, we're going to auscultate the lung fields and note the kind of sounds that we hear, making sure we don't hear any negative sounds. So we'll go ahead and listen to the front first. I want you to lean forward. Big deep breaths. Okay, so on the front I heard some bronchovesicular sounds closer to the bronchial trees, and then vesicular sounds across the healthy lung tissue. Okay, and on the back I heard vesicular sounds throughout. Clear to auscultation, no stridor, wheezes, crackles, friction rubs, or rhonchi. His respiratory rate was 16, which 12 to 20 is normal, and he has a normal respiratory rhythm. The last thing I'm going to check for is vocal resonance. I'm going to ask my patient to say 99. I should hear muffled through my stethoscope, and that is a normal finding. Say 99.
99. 99. 99. 99.
Okay. And those lung sounds were muffled, so that is a normal finding. Thank you for watching.